to go. Phone silence, action.
So hello to all the viewers. Welcome to this mega counseling session of the medical super specialties being organized by Doc Tutorials. So I'm Dr. Rahul Rajiv, neurologist and faculty at Doc Tutorials. I've got an eminent panel to guide you in this session. So without wasting any time, let me just introduce my elite panel to you. First of all, Dr. Bhaskar Rao Bolineni sir, a man of leadership and vision, needs no introduction, who is the founder and the managing director of KIMS Hospitals, a senior cardiothoracic surgeon. Welcome to the session, sir. We are pleased to have you. So now moving to the rest of my panelists, we have got from my left side, we have got Dr. Prashant Gandhi, sir, medical gastroenterologist. Then we have our medical oncology team, starting from Dr. Vijay, sir, Dr. Kiran, sir, Dr. Hemant, sir. We have got the elite nephrologist, Dr. Vivek Goel, senior cardiologist, Dr. Kamal Sharma, sir. Then I'll be dealing with the neurology part. Then we have got Dr. Nia, sir, for the infectious diseases super specialty. Then Dr. Karthik Vijaykumar for endocrinology, Dr. Vishnu for rheumatology, Dr. Ayush Goel for pulmonology, Dr. Manish for critical care, and Dr. Pooja also for neurology. So as you all know, we have floated a Google form to you to address the common queries that you have got. And yes, I have with me the queries that you have asked. And definitely you can ask more of your queries in the chat box as well. We'll be taking the queries as well. So let's start the session. So which super specialty should I start with? Cardiology? Okay, let's start with cardiology. So Kamal sir, cardiology often a favorite choice for rankers of the NEET SS. So upfront, let me just ask you about the scope of cardiology.
Hello everyone. Thank you, Rahul Rajiv sir. I think congratulations to all the successful candidates, and I wish you all the best. So as they say that no branch is better or inferior, it's you who make that branch better or so. So it's you that guides as to where you will end up. The cardiology is entering into a fantastic future model where AI is going to drive image-based intervention, diagnostics, predictive modeling, and a lot of other things are happening. You have subspecialty emerging, the structural, the EP has been fascinating now that you have atrial fibrillation, ablation coming up in a big way. A lot of technologies are emerging in that front, matching the success rates as which we previously thought were only possible for AVRT or AVNRT. You have structural in a big way where you have not only tower, but now you have even mitral clips, mitral valves, percutaneous replacements coming in, transplant, organ donation being the next foray to venture into. And of course, coronary stays with the new technology of plaque modification, even to the extent that there is a heart team approach which is emerging, and that's what I was discussing with the team, that even cardiothoracic surgeons and cardiologists need to work in synergy, and there is plenty of scope down the line with AI enabling further evaluation in the methodology we approach, diagnose, early treat, and treat them well. That's what the future of cardiology is. It's very interesting and exciting future that we are looking for.
Right. So thank you, sir, for your insights. And sir, we've got many queries from students on one particular aspect of cardiology, and not just cardiology, for other super specialties as well, is regarding the aspect of saturation. So do you think cardiology is saturated or will be saturated, and should a candidate have this in the back of the mind while choosing cardiology as a super specialty?
I think this concept of saturation, I would dwell in the format of comparison. If you were to compare how it was, say, 10 years back, that's not how the cardiology exists today, and it will not be the case even 10 years down the line. So what determines saturation is your mindset as to how you... There is saturation in terms of the numbers or availability of cardiologists in a city or a tier 1 city, but that does not mean that there is not enough work, because what is happening right now that we see a lot of patients of even hypertension being diagnosed first time, consulting a cardiologist rather than going to a general practitioner, an MD. So that way, if somebody is looking at as to how many angioplasties only I will do, that is not the right question to ask at this moment. And from that perspective, people tend to be misguided as to whether the saturation exists or not. And even from that perspective, I think it's not so, because there is enough of work in terms of availability of technology, no new avenues that I discussed, and tier 2, tier 3 cities which are still undertreated. We still have not reached a ratio of 1:2,000 as WHO mandates, even for generalists. So forget about specialists. So I think don't be worried about this aspect. Think what you like, because it's like a marriage. You're choosing a branch and you have to spend probably rest of your life with that branch. If you are in love with your spouse, that's when you stick around and don't think that you're going to be happy or not happy. You marry because you're happy. And same is with the branch. You stick with the branch. If you love that branch, go for the branch. And that's what's going to keep you happy. And a happy doctor is going to make the most of the career.
Right. Thank you so much, sir, for those valuable insights. And just one more query, regarding the college selection, DM cardiology versus DRNB cardiology. So, what is your comparison on this? Suppose if I get DRNB cardiology in a good institute versus DM cardiology in maybe a new institute. So, what is your take on that, DM versus DRNB?
Very good question. And this is a very important question also, because there are a lot of advantages that a good DNB institute has over a DM program. I think we did this video a couple of years back. I think we can find it on Dr. Tutorials app as well, where we had what are the points that you should look into in a slide format. We covered some 20 aspects, how to choose a branch. You can, our followers can go back there and go through that video as well. But in nutshell, the basic thing is that choose an institute which drives you into the Socratic bent of mind, which makes you understand the concept of how you deal and approach a patient. If there is a good institute that's going to guide you about how to approach a case which is not something that you usually see, which means that there is good academics, you can do publication, you can write, you can also get good hands-on, and there are good mentors to cater to you. And if this is a place where you ultimately, or in that city or in that area or in that state you want to settle, you would surely choose that DNB over a DM. But if it's a good DM institute and there are advantages that you want to look into from that perspective, as in it's a central institute or an institute at par with the central institute or institutes which is the best institute of the state in a government model, then probably that would still hold an advantage. But then there are concept and discussions around bonds, etc., which of course I'm sure as we proceed we'll discuss on those aspects. But I think don't choose just because something is DNB, you don't want to choose it. That should never be the criteria. Right. Choose a good DNB institute compared to what a not so good DM institute. It's probably fine. Otherwise, of course, DM or in general carries much higher weightage over DNB, as has been the trend, because that's where you're likely to get your seniors also doing in the similar fashion. Right. That was one of the points that we had discussed.
Right. Right. Thank you so much, sir, for those valuable insights on cardiology. Now, all of you are at this transition phase, right, from a specialist to super specialist. So let us hear from Dr. Bhaskar Rao, sir, on this transition phase. So to all these rankers who have achieved this big feat in the NEET SS examination, and they're just moving to the next phase of the professional life, what advice you have to give these budding super specialists, sir?
Good evening, all of you. First, let me congratulate that you have been selected, the super specialty, and your hard work, and the provided by the doctor's eminent panelists here who guided you to get into this. The one important thing what you need to is, you have come to a semi-finals, you need to go to a finals. When you are going for a preparation of the finals in these next 3 years, that is the place where you should be able to select. Today, the day has come, subspecialization, organ specialization. So with that, you should be able to select in this 3 years period, prepare yourself, which organ or which specialty you need to go, and also look that you want to go for a group practice or an individual practice. Every one of you has a chance to grow bigger, all is in our hands. The other one important thing I will tell you, wherever you go, you should also challenge to the patient, challenge to your teacher, so that you will gain more knowledge. That's how you should be able to build your career. All the best for your future.
Thank you so much, sir, for your blessings as well. We are extremely happy to have you here. And moving on to the next super specialty is endocrinology. And here we have got Dr. Karthik, definitely a student favorite. And to Dr. Karthik, most of the candidates have asked one query, that is regarding the choice of institute for endocrinology. For endocrinology, when a candidate is going to choose an institute, what are the factors that should influence his choice? Like, what all factors should be kept in mind before choosing an institute for endocrinology? Dr. Karthik.
Thank you, Rahul sir. A very valid question. And first of all, at the outset, I would like to congratulate all the NEET SS rankers who have come out with flying colors and are eagerly waiting on the opportunity on the counseling process. So first of all, I would like to begin. See, you may factor in a lot of things while choosing what is best for you moving forward, choosing an endocrine seat. But in the nutshell, I would say what eventually matters while you start practicing and start to build your career is the skill set that you acquire and the quality of the training that you're going to get in the next 3 years. So you can put in a lot of factors, but the two most important factors I would say, one is the depth and the breadth of the caseload that you're going to see. The variety of the cases, not just the number, but how you are going to approach it. So are you just being a passive listener, or you are actively putting your thoughts on it? This is very important, because while you are sitting in a busy OPD, later on while you are practicing independently, the thoughts should come automatically to your mind. So you have to practice and fine-tune this thought process while you are doing your residency. So your department should give you that space to do that. So that support is of paramount importance. So first of all, patient load. And second thing, that would be the presence of an accessible and approachable mentor or a faculty. At least 2 faculty would be of great importance. Why? Because there are many institutes across India who doesn't have even 2 permanent faculty. That would be run by 1 faculty, and he would be automatically busy with practice, and he would not have enough time to invest on developing the qualities of the trainees. So when you have a faculty who is dedicated on trainee upliftment, what automatically happens is that your academic programs become structured. The toxicity of the department automatically goes down, and your learning becomes an experience. So having a good faculty who is able to guide you, from my personal experience, I can say that it helps you a lot in your upcoming professional life. So apart from these 2 factors, the other things like having a good research background in the department, where you have research projects going on, and if having the faculty who is research oriented is important, then having an own endocrine lab which will help you exposure to the laboratory endocrinology, again a very important part of the endocrine practice. Then of course the collaboration with the other departments like the nuclear medicine, the radiology, the endocrine surgery, and how you are able to build a multidisciplinary team for managing complex cases. And last but not the least, the reputation of the institution and where the alumni of the department currently fares, and of course the presence of bond. So these are the factors I would factor in as the secondary ones. But remember, the 2 most important things being the caseload, how you approach, and the presence of mentors. So that is why it is very important to speak with the residents who is doing the residency currently, and also to the ones who have passed out from the department.
Right. So thank you so much, Dr. Karthik, for the valuable insights on endocrinology as a super specialty and the factors that influence your choice as well. So next, we'll move on to nephrology. Okay, so we have got Dr. Vivek Goyal with us. So, Dr. Vivek Goyal, many of the candidates have asked this question. How do you see the role of a nephrologist evolving in the next decade with advances in transplantation and interventional nephrology. Where do you see this branch going?
Thank you for that question, sir. At the outset, a big congratulations to all those who've managed to reach this point in life where you've crossed probably the last and the biggest exam of your life. And of course, when you appeared for the exam, of course, all of you are MD, DNB medicine residents. And if you are an internist at heart, trust me, nephrology is the best subject you can choose. Because what I feel is nephrologists are the best internists. Why do I say so? Because I think it's a perfect blend where you get infectious diseases, you get electrolyte disorders, you get OPD practice, you get a fair bunch of indoor patients, you see critical patients, you do procedures like dialysis lines, sperm cats, biopsies, and of course, in the era of kidney transplantation, which is probably the next big thing, now you also have a lot of exposure to curative nephrology, where you can do kidney transplant and relieve those end-stage kidney disease failure patients who were earlier only had the scope of getting dialyzed. So that's why I feel that nephrology is the perfect blend of everything. And as it is evolving, as Sir said, that precision medicine and immunosuppressive medicines are going to play a big, big role in the next decade or so. And AI has also come in a big role in the way it's making the predictive models. And I think the future of nephrology is going to be very, very bright. On the brighter side, it's also very lucrative. On the demand side, I would say, I rarely know a person who is in nephrology and is out of work. In fact, nephrologists can't complete the work that they have at hand. So I feel if you want to pursue nephrology, it is a subject you should choose.
Right, right. I think very clear on those points as well. Now, next we'll go on to rheumatology. Okay, so a lot of students are asking, endo versus rheumat. Are these relatively lighter super specialties? Do not know, but endo versus rheumat. So my question to you, Dr. Vishnu, is who should opt for rheumatology?
I know that rheumat is, I think, one of the favorite subjects. Last time, I think the top 10, there were 5 people taking up rheumat. But at the same time, you shouldn't go just because, your seniors took it. That's not how it should be. You should know what are the pros and cons. So those who should take rheumat are, I'd say, the ones who like Sherlock Holmes, the ones who like to watch House MD, etc. So it's a very thinking branch. It's a branch that problem solvers would like, as opposed to those who like protocolized medicine. It's not very protocolized. And the other thing is it's quite lucrative in terms of opportunities. If you look at the institutional practice, you have a lot of opportunities because, again, not many people apply. If you look at individual private practice, it's very easy to set up. So in that way, it's good as well. Corporates as well, every corporate needs at least one rheumatologist and the supply is very less. So you get placed very early, especially in the your DM, even going ahead, your work-life balance is very good, like endocrinology. At the same time, there are some cons as well, like every branch would have. So firstly, if you want a patient to, get, healed quickly, and you want that gratification to come up instantly, that will not happen in rheumatology. It is a chronic process. It's a slow process. So you won't get that, feeling that you might get in a branch like critical care or cardiology. At the same time, if you want, lots of money per se, or in terms of lucrativeness, extending through your career, that is not something that you can expect in rheumatology. Also, if you don't like uncertainties in practice, if you want things to be very clear, because a lot of times, patients won't fit into a specific diagnosis. In those cases also, you might feel it weird if you're practicing as a rheumatologist.
Right. Really valuable insights there. And students, you can just ask your queries as well in the chat box. We'll be taking your queries, once we are done with the set of questions that you have already given us. Okay. Next, coming to our branch, neurology. So myself and Dr. Pooja Anand will be discussing in the aspect of neurology. So with regards to neurology, common question. This question is for you. What do you think? Should this factor, be considered seriously before taking neurology as a career option?
Thank you so much, sir, for that great question. Now, this is a common misconception which we see. So, neurology, the neurodegenerative disorders are a part of neurology. They are not the complete picture. In neurology, the major chunk is formed by disorders like stroke, epilepsy, the neuromuscular junction disorders, autoimmune encephalitis, and many more, which are treatable and curable disorders. And now with so much of advancements in disorders like stroke, if we pick it up early, we are almost able to give a near total recovery. And even if we talk about the neurodegenerative disorders, the story is not what it used to be, say, 10 years ago. We are not giving them the death sentence or something like that. We have so much of advancements where we can improve their quality of life. And now with treatment options such as lecanemab for Alzheimer's, we are even able to reverse or even halt the progression of disease. So I would say that neurodegenerative disorders should not be a deciding factor on choosing neurology.
And also the next decade is going to be really exciting with the AI, especially, with regards to neuroradiology. The precision of making a diagnosis is going to improve. Then with regards to EEG reporting, definitely, the precision of reporting will definitely improve. And neurology is a wonderful branch, and I think the best one. Okay, so that's what I think at least. Okay, so keep that in mind. Another question about neurology is regarding, the points to be kept in mind for selecting a college. So I've just jotted down 10 important points to be noted while opting for a college for DM/DRNB neurology. Okay, just I'll quickly go through it, and this applies to most of the super specialties as well, so not just neurology. Number one, average number of OP cases. Good caseload is very important for your training. Number two, about the number of IP beds, because that is important. The number of IP beds is definitely going to give you an indirect estimate of, okay, like what sort of a case workup is happening in that department as well. Number three, very important, well-equipped ICU setup, because you have got to be good in neurocritical care as well, and not just, the routine OP cases. Number four, a well-equipped electrophysiology lab, very, very important. Number five, a good radiology support. You should have, especially with stroke and advanced imaging as well, you have to have facilities for CT, MRI, and advanced imaging modalities as well. That will be great. Then a streamlined academic program. You have to talk to maybe seniors and try to understand how the academic program is, like whether you have got clinical case discussions, topic presentations, journal clubs, because such sort of an environment is always very important to bring the best out of you. Okay. Then number of faculties, more the better, because if I talk from the neurology point of view, it's mostly a clinical branch. As we get more exposure to multiple number of faculties, our approach also gets refined. So it's always good to have multiple faculties, and you can refine your own approach, seeing the approach of other faculties as well. Okay. Then number of co-postgraduates, again, very important. You've got more senior residents working with you, which means, there will be a balance between the work as well as, the academics as well. So more senior residents, the better it is. Then number 9, good support from other super specialty departments. Like, even if you want to become a neurologist, you have to have a good rapport with the cardiology department, for echo. So, nephrology for dialysis. Obviously, Vivek and his team will help us anytime in need. So, last and not the least, before you opt for a college, it's very, very important, talk to a resident working there. Okay, because the dynamics of a department keeps on changing. Because see, the head of the department decides on how the workflow of the department is. So, over years you can have changes in the structure of the functioning of the department. So please talk to a resident, preferably not a first year resident. Why? Because he's the most overworked person. So you call him and you ask, academics, wonderful, how is it? He might be in the midst of maybe continuous duty. So maybe first year may not be the ideal person to ask for, maybe a second year or a final year resident or a recent pass out. Okay. So these 10 points are very important, and there is no perfect choice. So do not think that, you are going to get a 10 on 10 for, many colleges. No, but just like, Kamal sir was equating this to a marriage, whatever is best for you. Okay, and
You make the best out of it.
that is also fine. Okay.
Whosoever you marry, you make the best
Make
out
the
of
best. So, you have to do it in such a fashion. And again, let me tell you, see the world through your spectacles. A college that may be a better option for me may not be the better option for another person. So when you decide on a college, think of multiple variables. And as I say, see the world through your eyes. And that is very, very important as well. Okay, right. Now, moving on to the next set of questions that we have got. We'll come to Dr. Ayush Goel, sir. So this is regarding pulmonology. Sir, we have got MD pulmonary medicine. Why DM pulmonology? So can you shed light on that? Like, if at all a person decides to go for a DM pulmo, like, why should he go for DM pulmo?
So I think I'll be a good person to answer that, considering I've done my MD in medicine and then chosen to do DM pulmonary medicine. So we have to understand that pulmonology as a branch has evolved tremendously in the last decade. It is not just about medical management of common diseases like COPD, asthma, etc. Now we have a lot of different avenues, like a lot of interventions are being done in pulmonology, like gastro. We have lung transplantation, we have ECMO, critical care, sleep medicine. And in order to get trained in all of these aspects, a 3-year MD program is not enough. And just like any other specialty, like a rheumatology or a gastroenterology, we need more time, more expertise, skilled centers where people can get trained. And that medicine is evolving so fast, you need people who are specializing in extremely small things, like a person is specializing only in interventions or only in lung transplantation. And for all this, a DM program is much needed over an MD pulmonary medicine. So for people who are opting DM pulmo, even after doing MD medicine, I think it's a wonderful branch because you're getting OPD practice, you're getting IPD practice, you're getting your handset on interventions, you have critical care exposure, you have sleep, so you can open up your own clinics or have an hospital-based practice. It gives you all aspects of medicine as a whole. And if you want to choose colleges for doing your DM pulmonology, I think one factor that has to be considered, apart from obviously the number of seats, faculty, etc., is the equipment. Because one of the reasons why you're doing a DM over an MD is because you want to get trained in expert interventions. So at least basic bronchoscopy, EBUS, thoracoscopy, if possible rigid bronchoscopy. So choose colleges where, these procedures are being done, and other facets of pulmonary medicine like sleep medicine is there. And if transplantation is there, although it's not there in the government setup, is there, that will help you become better pulmonologists.
Thank you so much, sir. Thank you so much for those insights. And next, coming to medical gastroenterology, I can see so many queries also, mostly with regards to the scope of gastroenterology. In the comment section, John is asking about the income of gastroenterology. So we just want to know whether Prashant Gandhi sir owns a BMW or a scooty. Let's try to find out from him. So Prashant Gandhi sir, regarding the scope of medical gastroenterology in the near future, how do you see this branch going?
Thank you, sir. Thank you for the wonderful question. And congratulations for one and all for all the great ranks you guys have scored. And coming to the scope of medical gastroenterology, it's just amazing, guys. Why I'm telling you this is, if you see the statistics in India at this point of time, if you see the population, majority of them are going towards their middle age and towards their older age, and many people are surviving because of all the super specialists around. So what I would say is, as the population ages, we are going to deal with too many different problems. From a gastroenterologist perspective, it is just not a single organ based branch. We deal from esophagus, stomach, pancreas, liver, and liver is so busy that we even have a separate branch called hepatology. We deal with colon, and literally we have too many things to think about, and it's also a mix of too many things. Few years ago, general gastroenterology was the only thing actually known where endoscopy and colonoscopy and to some extent ERCPs were done. But nowadays, we have such an extent of elaborate advances in the branch. To name a few, you can be a part radiologist. You really need to have an expert knowledge in the internal anatomy from a radiologist perspective. So we have an endoscopic ultrasound guided complex procedures. If you are not feeling okay with just this, you can even train yourself into something more specific, more surgeon oriented, called as third space endoscopy, where you can start removing some small polyps, bigger polyps, some submucosal lesions. You can do POEM for achalasia. You can do surgical procedures in a very minimal invasive ways. Other way to see is there are a lot of patients nowadays coming with functional disorders, what we call as DGBI, disorders of gut-brain interaction, where a lot of functional patients do come and you will have to treat them, and newer molecules like neuromodulators are also coming in place. Apart from this, there are newer ones called as neuromotility disorders, where again, lot of inputs, pressure readings, manometries, lot of inputs are there. So as a branch, gastroenterology is diversifying, and even after gastroenterology, we are quite busy with the varied this thing. Like sir already alluded, group practice where an individual gastroenterology group would have further subspecialized gastroenterologists dealing with each of this, and each of them are themselves quite busy. You have something called gastro-oncology coming in place over time, and there are a lot of things happening. So the scope for next 50 years, I think gastro would be number one.
Right. And sir, like another question by a candidate is, how different is gastroenterology from hepatology? Who does procedures, and does choosing hepatology limit long-term practice or income?
Okay, again, let's look at statistics. We have an aging population. Many people are living longer because of all the other branches. So the propensity or the number of patients having liver diseases, especially NAFLD, what we call as MASLD now, is increasing disproportionately. So the liver diseases like chronic liver diseases are increasing. The complications because of chronic liver diseases are also increasing. The indications for liver transplant is also increasing. So there is a diversification of the branches, and liver transplantation and the sick liver patients, they deserve special attention, because a general gastroenterologist may not be able to cater to all the sick patients. So there is special entity and a requirement, and hence the branch has come. And from an income perspective, at least from scope perspective, there's a significant scope for hepatologists. But what we also have to see is there scope for income? Of course, income, if you see a general gastroenterologist who is doing endoscopies, colonoscopies, ERCPs, the prevalence of these cases coming, the incidences are quite high, so it is small amount but a continuous amount. But if you see a hepatologist, he would do 3 to 4 liver transplants, and probably as a group practice make much more revenue than an individual general gastroenterology practice. So income wise, sky is the limit for whatever you take, let it be gastroenterology or let it be hepatology. But from a practice perspective, some students have a common question of, is an hepatologist medico-legally okay to do endoscopies, colonoscopies, ERCPs? Absolutely. If you are trained in these procedures, doing your DM or DRNB courses or other advanced fellowships later, you can definitely do these procedures also. And some of the hepatologists who I know are also practicing medical gastroenterology and hepatology in tier 2 and tier 3 cities, because at this point of time, liver transplant is being predominantly done in metropolitan cities. But mind you, there are many colleges, even medical colleges, they have started doing liver transplants. So as a country, we are going to expand like anything. The aging population is always there, so the demand is evergreen at this point of time. Thank you.
Right. Thank you so much, sir. And just to take a query in the chat box is by Dr. Bharat. I think it's to Bhaskar, sir. It's about KIMS neurology. I think he's planning to take KIMS neurology. So, sir, what do you think about the choice of KIMS neurology? But I'm sure that, I personally know about the neurology department of KIMS, especially in segments like epilepsy, Sita Jalakshmi ma'am. I think it's a wonderful department that they have got at KIMS. But again, Bhaskar sir, regarding KIMS neurology.
In the last 4-5 years, whoever got the first 3-4 ranks, all of them selected in neurology in KIMS because of the group practice and the amount of technology that we have, and the amount of treatment clinically more than diagnostically, and whatever the technology that is available in neurology in KIMS, not many hospitals, maybe 1 or 2 hospitals have that much of technology, and good teachers, all of them well trained, more than 20 years in Nizam's Institute of Medical Sciences, and backed by the neurosurgery department, one of the best department in India. So with all these things, I think you better select KIMS.
Thank you so much, sir. Thank you so much. And now we'll come to our medical oncology team. So we've got, 3 eminent medical oncologists with us. So first, scope of medical oncology in the current era. So Hemant sir.
Yeah. Hearty congratulations to everyone. Now the scope. So in case you like medicine, you enjoy medicine, where you have no restriction to any organ, that was where I was, that I had the love for medicine, and probably I did not want to super specialize. But then medical oncology is one field where you're not restricted to definitely to one single organ. Just yesterday, I had seen somebody with cardiomyopathy. I had got somebody who had developed AKI due to our therapy, had somebody who was developing GBS also. So you will end up at least clinically diagnosing this. Definitely you will rely on your colleagues for management, but you will end up seeing this every day. The second most important point that I would probably stress upon is the security of the field. Now with this basically comes when I probably had to choose either ID or endocrine if I was thinking. There a lot of physicians end up managing these conditions. So you will be thinking, what will happen in case I do take up, will I be able to sustain? Medical oncology is one field which definitely I am guilty of during my MD medicine also, that if I had a patient with acute leukemia, the next moment I will be kind of really pushing the patient out of my hospital, sending you to an oncologist. So you are on the receiving end. As oncologists, your job is extremely secure. The moment a malignancy is diagnosed, nobody wants to touch it. So the reference usually goes to the medical oncology, so your job is safe. So it is a very secure field. You love medicine, definitely yes. If you like to work as a team, definitely medical oncology, because almost every other solid tumor goes with radiation oncologist, surgical oncologist, medical oncology, pathologist, and the radiologist. So teamwork is going to be definitely wonderful. And if you look at the spectrum of patients that we see, you have a lot of solid tumor patients, you have early screening, early malignancy that are being detected, highly curable that way. You have got hemato-oncology that you still end up treating lymphomas, myelomas, even leukemias. You've got pediatric oncology as well. And the other extreme, the new toy for us is immunotherapy, targeted therapy. Greatest advances that probably you're going to see. FDA approves over 50 drugs or indications every year. That is how fast medical oncology is evolving. And in case you ever want to win a Nobel Prize, better take up medical oncology. And at this point, I also want to probably tell a small joke. You asked gastroenterologist about the money. Yeah. The one thing that gastroenterologist, the BMW he had to sell it to invest for his scopes. Medical oncology is zero investment, and the medical oncologist got the BMW.
Okay, that's good. That's good. That's good.
So your investment is hardly anything. You don't have any investment. Lot of cancer centers opening around. the scope is definitely there. It is an evolving and emerging subject. I think with him telling that people are aging and surviving and gastroenterology is very good at his work, the possibility that somebody might develop malignancy later is higher.
And I think, sir, by choice as well, I have seen this time more number of candidates attempting the medical oncology exam. So I have seen this natural bias coming towards medical oncology as well, right, sir?
The number is definitely increasing. People are understanding that cancer is not illness that is associated with death. That is how probably it was portrayed during our time. In fact, after infectious diseases, cancer is the next most curable illness. The numbers are increasing, the chronicity is increasing, the therapeutic aspect that you're having is just drastic. Even I can't remember most of the things at times. So every day you have to learn, you want to learn, there are enough and new things that are happening. So definitely oncology is going to be there.
And coming to Kiran, sir, again, choice between DM oncology and DRNB, your take on that?
You already told of the 10 points.
Yeah.
So I would say that a DNB from a good institute is equally valued as a DM. When you pass out, people usually do not differentiate whether a DM or a DNB candidate. With respect to jobs, don't worry about it. Just choose the institute correct. You talk to the seniors who just passed out at the final years. Don't call the first years. And once you make the list of those hospitals, once you talk to those people, you need to ask, apart from all the points Rahul sir has told, whether a hospital has only solid tumors predominantly, or do they do hematology also, or do they have bone marrow transplant facility. If you are already decided that you don't want to practice hematology or leukemias, especially if you're already from radiation oncology background, you can select institutes which predominantly treat solid tumors. But if you're really interested to practice hematology also, then you choose an institute which has a bone marrow transplant facility. That is one important thing. Second thing, choose the mentors. Whether the faculty are good, whether they are approachable, whether they let you see OPD, especially in the DNB. DM, so anyway, you'll have to see the OPD yourself. But many of the DNB hospitals, you might be just an observer, and you might not be able to see the patients. So make sure that you have the opportunity to see the patients along with the consultants, and you are able to discuss with them. And then the academics happen regularly. And the patient load. The patient volume should be high, OPD numbers and IP numbers. And the stability of the faculty. If the faculty keeps changing or the management keeps changing, that is also again a red flag sign. So take all this into consideration and don't worry about whether it's DM or DNB. I would say DNB from a very big, very good institute, I value more than a DM from a very low quality institute.
And is the tag important, like any particular institute, tag value is there for oncology, sir?
So definitely in DM, there are top 5 institutes, and then tag actually helps, not a big way, in a small way, but most importantly, I would say the tag helps for more networking.
Okay.
So you will get more contacts through the tag rather than more opportunities. I think if you are sitting in a place and then doing good practice, people will ultimately recognize you in 1 or 2 years, and tag is not important at all. I joined Tata and then I moved to IDR.
Right.
Doesn't make any difference for me.
Because that is also very important, for the students to know as well. Now, coming to Vijay sir, next query by students is mainly regarding the work exposure, like bone marrow, CART, immunotherapy. So your insights on that, sir.
A very hearty congratulations to everyone. I think my voice is a little low, but still, see, as he has already told, deciding on what you're going to practice makes a huge difference in choosing the institute. If you're wanting only to stick to solids, almost every other medical oncology institute is going to have so much of solid load. In that perspective, get into the academics and find out if the academics of that institute is good in terms of engaging you into journal clubs, regular meetings in terms of case presentations, and updates and usage of all these immunotherapies and CAR-Ts. If you are equally interested in hematology and also in solids, then you will have to be very particular in choosing where there is so much of hemat and also transplant, because now people will want to kind of do transplant if they are wanting to do hemat also. So wherever there is a transplant program which is actively going on with so many patients getting listed for transplant, in such an institute, if people are able to choose, that will be a great help.
Right. And sir, regarding scope of hemato-oncology, a question is being asked by Dr. Tanvi. So your take on that.
Yeah, I'll probably take. I think hemato-oncology is again a very evolving field, and it's a fantastic field.
Right.
So again, when you kind of decide on an institute, you need to look at what you're probably going to practice in the future.
Okay.
If you like benign hematology, okay, benign hematology has got a lot of scope because this is going to be a more chronic disease. They're going to be there with you for long. If you like hemat malignancies per se, again, there's a whole bunch of it: lymphoma, leukemia, myeloma, which are always been there. And the next bigger thing is the transplant. Now, transplant, yes, you need to kind of have a dedicated system, very good training, probably go for training further beyond that, because it might not be enough for just few months during your residency program. But as of now, what is happening is medical oncologists are practicing, but from a physician bias or physician point of view, I have started seeing less of chronic leukemia, CML, CLL, probably because they are being referred to hematologists. Okay. So people are recognizing the value for hematology. So I think hemato-oncology also is a fantastic field to be.
Right. And I'm seeing that Nia sir, our infectious disease faculty, there are so many queries this time, about infectious diseases. I can see Dr. Veena, Dr. Elizabeth asking questions. So it's mostly on the scope of infectious diseases, relatively a newer super specialty. So how do you see this, especially the long-term scope, as a career option?
Thanks, Rahul. I'll start with disagreeing with three of our faculty. You think that neurology is the best,
Yeah,
but,
no, no.
But I always believe that ID is the best. And then Vivek thinks that nephrology is very close to internal medicine. But we believe that infectious disease is the closest to internal medicine, and nephrology comes a very close second.
Okay. At least you got second. Okay, be happy.
I already credited you as the most curable disease.
So all of you will have to call me for CPR.
And third, Vishnu thinks that rheumatologists are the Sherlock Holmes, which we again disagree. Like, we think that we are the Sherlock Holmes, or whoever detectives who find most of the undiagnosed diseases, and sometimes we pick up rheumatological diseases when we look for infectious diseases. When you're talking about the scope, like, that is something that we are all worried when we started our own DM program at AIMS, which was like not very long back, and whether, like, who is like going to employ us, like how will be the scope. And trust me, we are all employed now. Like, we have finished like the course, like, and nobody is like unemployed after taking infectious diseases. The scope is there. Like, every week I get a call from like some corporate hospital looking for an infectious disease patient, okay, because like there are not many of us as of now. So antimicrobial resistance is increasing, and if somebody thinks that anybody can use antibiotics to treat these complex infections, it is wrong. Every corporate hospital is going to look for an infectious disease specialist. It has become a necessity, and hospitals are recognizing that. That is something I'm very sure of. And apart from that, it's not just antibiotics. There are a lot of other complex infectious diseases. Transplant, every like corporate hospital is now doing a transplant. The gastroenterologists will be doing, nephrologists will be doing. But infections are going to happen, and you'll need us for treating that, so definitely. And adult immunization is something that is going, everybody is now accepting the role of adult immunization, so that is something you can practice. Apart from that, there is travel medicine as well, and sexually transmitted infection. Increasing in a big way. A lot of patients come for the post-exposure prophylaxis. We still have a lot of HIV patients coming. So all these things are there, so there is no problem with the scope of infectious diseases. And then you have to decide how do you want to practice. So most of us would like to practice as consultants, seeing consultants from the other branches. So in that aspect, the work-life balance is good. If you're not admitting your own patient and attending to consultation from other departments, I think the work-life balance is quite good. But then you can always choose to admit your own patients. You can also choose to own your own clinics also. Many infectious disease specialists do that as well. And in that aspect, earning should not be a problem. And the starting salary of an ID specialist as of now, I think, is almost equivalent to any other specialties, is what I believe. So there is no problem with the scope. And I can assure that if you have an interest in internal medicine, and if you like microbes, you will not regret choosing infectious disease as a specialty.
Thank you so much, sir. And I'm sure that many of you know, sir is already doing very good work in the field of infectious diseases, especially, with regards to the Zika virus outbreak that happened in Kerala. Sir was pivotal in the, the diagnosis part. In fact, their team at, the hospital was very, crucial in the identification. So next we'll come to critical care as a super specialization. So who should actually opt for critical care, and what is the scope as well?
Thank you, Rahul sir. Thank you for asking me last. Congratulations to everybody who did well in the examination. So thank you for asking me last, because if you were hearing all of them, claiming that their specialty is best and confused which to choose critical care. Because you get to see everything, right? Literally everything. You get to take part in dialysis. You get to do bronchoscopy. You get to do some part of surgery like tracheostomies. You get to do infectious disease, gastroenterology, cardiology, so everything. So that is the benefit of having critical care. So as everybody else seem to think that their specialty is best, I seem to think mine is best. And I also seem to think it is closest to medicine. But the problem is it is not traditionally taught like medicine. It is not traditionally taught like medicine and not seen as part of medicine, and that is why the problem exists there. And the major problem is there is no OPD based practice with it, like with every other specialty they have. So if you are not looking for an OPD based practice, or if you are looking for OPD based practice, then critical care is not for you. But if you are okay with that and want to practice medicine in general and enjoy doing procedures and taking care of critically ill patients, then obviously critical care is for you. Now, what is the scope? So as we have got to know about it during COVID, that the number of ICU beds in our country is like what, 1% or 2% of total beds in the country. So obviously with the increase in the number of ICU beds, everybody is trying to expand their capacity of ICU beds. The need for critical care physicians will be more with the coming time. How? So one rheumatologist or one ID physician can take care of the whole hospital, but ICUs need multiple critical care physicians. A critical care physician cannot take care of more than 8 or 10 or 12 patients. That is the recommended limit even by Indian societies, that one critical care physician should not be taking care of more than 8 to 12 patients at a single time. And so with the increase in number of critical care beds, you are going to have increase in demand of critical care throughout the country. And like sir said, the starting salaries are the same for any of the specialities almost in metro cities. But the problem is the limit. So since you don't have the OPD practice, since you're not bringing in the number, you hit the ceiling faster sometimes at times. And that depends on you, basically. I've seen people who do their private practice as well and all those things.
And between DM versus DRNB critical care, regarding the choice?
So, sir, I think you have covered it very well. You should look for certain things. You should not go behind DM versus DRNB. Instead, you should go behind what you want from an institution. So if an institution covers all the basics, like they have a good transplant going on, so that you get exposed to transplant. So if they have good oncology section in the hospital, so you get to take care of onco-critical care. If they have a closed ICU setup where you can do a lot of procedures yourself, you can decide on CRRT dosing and all of those things yourself. And if they have a good ECMO program, they let you do bronchoscopies. So all of those, if the criteria are getting fulfilled, those will be a better option compared to going for DM versus DRNB. So the problem is many of the good traditionally DM choices don't have all of these criteria fitting in them. So that is why sometimes if you'll see the previous year rankings also, sometimes DRNB gets picked up faster than DM in many places. So yeah, I think running behind DM versus DRNB is not very logical in critical care.
Right. And Dr. Karthik, I'm seeing so many comments in the chat box regarding scope of endocrinology. So what is your take on the scope of endocrinology?
Yeah, sir, I've been listening to all the conversations very keenly, and I think most of the specialists were claiming, I would say it's a tall claim, that my specialty is closest to the internal medicine. So if you want to stay to a specialty which is closest, you better would have stayed in internal medicine itself. See, you had chosen a specialty because you are interested in that specialty. And So I have dwelled in endocrinology. I'm not claiming that it is closest to the medicine, but again,
It is. Here far off. Cardiology.
So, there are many aspects which the previous panelists have pointed out, that they have exposure to the acute care, exposure to OPD, IPD practice and interventions. But there would be at least a subset of students just like me who are not very much interested in emergencies, who would like to have a good night's sleep every day, not worrying about the patients, the sick patient whom they have admitted. So endocrinology is one of the best specialty for you, which give you a good balance between the academic, research, your clinical practice, and even for like the public policy making programs now. You know, all these lifestyle diseases like the diabetes, obesity, the osteoporosis, menstrual disturbances are all increasing day by day. And you have very, very effective molecules also, like the GLP-1 analogs, which is now available in our country and is being used very, very commonly. And this has made a drastic impact in our clinical practice and have reaffirmed our place in the management. So Prashant Gandhi sir was like speaking about the MAFLD or the MASLD currently, which is mentioned, and whom do they refer to start these drugs on? They refer to an endocrinologist. And for obesity, for diabetes, so the landscape is ever changing. So if you want to choose a specialty which you are pretty sure that is going to last for a very long time, because in my state, Kerala, every 1 in 4 adult patient is a diabetic. So how on earth are you going to run out of patients? So as more and more endocrinologists are going to serve, now it's there the tier 1, now when more of them are going to practice in tier 2 and tier 3, see, more patients are getting aware that these are the super specialists whom you should consult for their diabetes, thyroid, and other endocrine problems. See, 10 years back, for a regular headache, all of you must have gone for consulting a physician. But now what has changed, and the first offset, you would go and see a neurologist. And that is what is going to happen. I think it has already started to happen in metropolitan cities, and it is evolving. And by, say, 3 or 5 years from now, I think almost 80 to 90% of the practice of your diabetes and other metabolic syndrome, if there are enough consultants in endocrinology, would be taken over by the super specialty. So there will be no dearth of opportunities. I can guarantee you that.
Right. So thank you so much, Dr. Karthik, for those insights. And one query is regarding, how to weigh bond versus institute quality. So Dr. Vishnu, if you want to take that question, in the choice of a college between bond versus institute quality, what is your take on that?
I think I can speak for rheumatology. Rheumatology, most of the good colleges, or like we have 6 government colleges, and all of them, apart from probably Madras Medical College, which is a little bit of a lenient in terms of bond, but all others have at least 2 years of bond, and they are like unbreakable bonds of like 2 CR or something. So you all, even me, when I was thinking about this decision, we all think bond is a negative thing. But let me tell you the positive side of it as well. So firstly, you get the experience of taking decisions on your own, because through our residency, through our 3 years, we're always guided. But those 2 years, you get that leeway to take your decisions on, practice your, polish your skills, practice your medicine, and, kind of get that experience. The next thing is, through this age, especially if you have cracked your entrances in one go, you need some time to settle. So if you're cracking these entrances, you do take a few months for yourself, for your family, etc. So that as well goes in this bond period. The third part is, when you come out of the bond, you are not looked at just a DM student. You're looked at as a post-DM, as an assistant professor from an institute. So that helps in building up goodwill among your peers, and also if you're planning on joining a corporate or starting your own practice, it builds up your career in a very good way. Even more so if you are doing the bond in your home state, then I think it's almost a positive rather than a negative.
So
thank you.
Sir, if I can add one more point,
please.
Endocrinology. See, this is one specialty where you can be your own boss, and many of the endocrinologists who have had a practice in the corporates are now independently starting their own centers, and when you are running your own center, your income also multiplies. So it's not just the consultation fee, the revenue from the laboratory, revenue from the pharmacy, so all these gets multiplied, and this will get you a good enough amount which will help you buy a BMW sooner than later.
If I can, Dr. Rahul, sir, comment. What is happening in medicine is that previously we were all looking at being the Arjuna and looking at the eye of the fish. I mean, cardiologists will only look at the heart, and the neurologists will look only at the brain. That concept is changing. You look at SGLT2s, you look at GLP-1, they are across the specialty. So don't think that by choosing super specialty, you are supposed to forget medicine. It's never going to happen. On a serious note, you continue to be a physician at the core of your heart. And a good super specialist will be the person who will be good physician first. And medicine is not going to, though become subspecialized, will continue to stay a generalist approach because the therapies are going to be across the board. Like I gave you example of SGLT2s or GLP-1 analogs, these are just a few names. It's used in hepatology, it's used in endocrinology, it's been used by cardiologists. Now today, the market says that SGLT2s are used more by cardiologists than endocrinologists. So even by nephrologists. So I think that we are also, more so nephrology. So we are entering into an era where even if though you become a specialist, you will not cease to surrender or end up surrendering your MD medicine degree. You'll have to be a physician first and then the super specialist.
Right.
So
And
one point, what we are constantly being asked on the chat box as well and also in our messengers, many students are trying to compare to institutes and asking us to answer which is the best institute to choose among the two or among the three. Now, as Rahul sir has already said, the points that you must think over before choosing an institute, but I also want to tell you that this is your choice. This you cannot ask any other person, because apart from the points sir mentioned, there can be some other practical points as well. Correct. Also, what the stipend is, that could matter to someone. Also, if the spouse of that person will get a job or will get a place to stay in that city or not, that also could be a point. Somebody can afford to live away from their parents, the parents might be ailing, might be aging. So there are a whole lot of factors, socio-economic, demographic, geographic, monetary, which only that person can understand who is standing in those shoes. Right. So as sir said, please look from your own spectacles, and that choice you have to make.
Right. So thank you so much, Dr. Vivek. And in the comment section, I'm also seeing many students with borderline ranks. Should I choose, with this rank, should I give it one more try? Look, if there is a branch that you are passionate about, that you desire to, move forward with, if that is the case, you definitely should go for that branch. That is what I feel. You should go for that branch. And if you get a good college with decent training, then in that case, you can opt for it. But if not, better not compromise. Suppose if you are having neurology as your first choice and maybe you're not getting, or maybe if you had endocrinology as your first choice and you're not getting endocrinology and you are getting, say, neurology. If you have a decent liking for neurology and you think, okay, I think, I'll be good with neurology as well, then proceed. But if still your heart is with a particular super specialty, whatever it be, okay, because as I said, all of us, we are all happy with whatever super specialty we have chosen. That's because we are all passionate about what we are doing. And that's why each one of us vouch that ours is the best. And that is the attitude which each one of you should be having. So what I would like to tell each one of you is follow your heart, not cardiology, but your heart, okay, and, make a choice accordingly. If you feel that, no, I have not got the branch or maybe the college that I wanted, give it one more try. This is what, I'd like to say. So that's it. We have had a wonderful discussion from the eminent team of panelists that we have got here. I think, a lot of insights, lot of inputs, lot of fun. So, we just want to wish all of our dear students the best in your future. And Bhaskar sir, any closing comments to the, the young super specialist?
It's a very interactive session today, and every one of them has been pointed out. Few important things I'll tell you. Everyone, of course, all of us will study only for the finance. I can tell you that every branch, every individual is paid in KIMS. Minimum 5 lakhs, maximum is 5 lakhs as an individual. As a group, as a department, he will get around 50 lakhs to 1 crore because so many consultants are there as a group practice. So how to achieve this is 50% of you, 50% based on other factors. Why I say 50%? The day when you think patient is your God, he will be able to gain lot of knowledge. Why is God? He is the one who is teaching more than teacher or anyone else, and he teaches you the communication skills provided if you answer all the questions put by the patient. The third important thing is he is the sole marketing agent for you. Wherever you go, he will be able to tell so and so is my God. The fourth important thing is he connects to the community by way of writing papers or anything in the journals and other things. So please keep all these things in mind. That is one thing. Second important thing, how to get a knowledge. You should be able to decide the difference between a consultant and a student. You are no more a student, you are a consultant under supervision. The day when you think that you are a consultant under supervision, then you should be able to point out what is the differences between a student and a consultant. Consultant one is the one who takes care of the patient from the beginning till he get discharged and keep following up. A student, undergraduate or postgraduate, you see bits and pieces of the patient journey. So there you don't get any knowledge out of it. So the best is whenever you are a super specialist, you should be able to see from the beginning, from the emergency or from the OPD till he gets discharged, because you are only looking into the one department, so you can able to follow all those things. So that way you can able to gain more knowledge. The day when you are able to see, for example, myocardial infarction or acute kidney damage or acute stroke, if you read at the same day entire thing, from next 3 years if you are able to see next 40-50 patients of a different variety of presentations, then you will gain the most knowledge. So that's why when you come out of after 3 years, you will become so much knowledgeable. The fourth important thing you need to be able to see, how you need to be able to assess your patient by putting questions why, what, how. So you are not there to write any investigations. Before writing any investigations, you should think, why am I writing this investigation? What am I going to get out of this investigation? What I am looking for it? And what you are going to see on the X-ray or MRI or CT or any other blood investigations, you should be able to assess. That means you should understand the entire pathophysiology of the disease and the changes that is happening in the body, so that you can able to guess. The diagnostics, whatever you write, it is only to confirm your knowledge, not that you are going to get the diagnosis from the diagnosis. The day when you are able to follow all these things, definitely you will become the best physician. Any branch you select, don't worry about whether I got a first rank or a last rank. Any branch, if you select, whatever I said I followed, if you are able to follow all these things, you will definitely get a better rank. The other important thing is you have to see some papers you should write, some research you should do. That's where the innovations you will be able to develop on your own. Once you start developing your innovations, the knowledge you gain is much superior rather than just mugging up and writing the exams and coming out. With all these things, I am sure once you follow, you will be the best person and best suitable person. And there is nothing like a place. Every one of them, whether it's a tier 1, tier 2, tier 3, most of the consultants make the same amount of money. But only thing is, you will be more accessible quality when you are in tier 1 cities with a multi-specialties approach. If you are an independent, you make more money, but your quality may not be there, then you cannot able to look in your community is one of the topmost physician in the department. So I heartily congratulate again, you follow all the things what I said, and you will become the one of the best physician
Thank you so much, sir. Thank you so much for those words. And just one last closing comment. Yes, you have all learned from us as our dear students at Doc Tutorials, but we have also learned a lot from you because of your doubts. It has pushed us also to learn better, and for the next batch of students, we'll try to give even better training as well. And we love you all with all our heart. Thank you so much for joining in this session. Thank you so much, and thank you to all the panelists as well. Thank you so much. Bye-bye.